Welcome back to the International Journal of Gynecological Cancer Conversations, the November's editor choice. We're diving into some recent publications that caught our eye. I'm Paula from Houston Methodist Hospital in the US.
And I am Matteo Loverro from Policlinico Gemelli, Rome, Italy. Always great to dive into the latest research. Hey Paula, we've got three really impactful papers today focusing on critical areas in gynecologic oncology, including rechallenging immunotherapy in endometrial cancer, aggressive histologies in endometrial cancer, and ADC safety.
Agree. Let's dive right into our first paper, which addresses a growing clinical dilemma: how to treat patients who progress after initial immunotherapy. The article's title, Checkpoint Inhibitor Rechallenge in Advanced Endometrial Cancer, Revisiting the Immune Landscape Beyond First-Line Therapy. And the first author is Vivek Poddar, affiliated with Mount Sinai Medical Center, the Division of Gynecologic Oncology in Miami Beach, Florida, USA.
That's a perfect starting point, given how rapidly ICIs are being incorporated into frontline endometrial cancer treatment. What was the core clinical problem this review aimed to address?
The central issue is managing progression after prior immune checkpoint inhibitor exposure, especially now that agents like dostarlimab and pembrolizumab are standard for deficient MMR, MSI high tumors, and combinations like pembrolizumab plus lenvatinib are second-line options for proficient MMR tumors. Even in deficient MMR populations, which are typically sensitive, 10 to 40% of patients in frontline trials progress within 12 months.
Wow, that failure rate is significant, but what's the evidence base for trying rechallenge then? Is there prospective data guiding us?
That's the catch. Currently, there are no prospective trials designed to guide immune checkpoint inhibitor rechallenge. However, rechallenge is already occurring in practice. We know that in the RUBY trial, 35% of patients in the dostarlimab arm received subsequent immunotherapy off protocol. This gap between practice and evidence highlights the unmet need.
So if clinicians are doing it off protocol, what do the early retrospective signals suggest about its plausibility, particularly in biomarker-defined subgroups?
The retrospective data is encouraging, especially for deficient MMR tumors. For example, Morton and colleagues reported outcomes where 6 out of 11 endometrial cancer patients responded to second-line immunotherapy rechallenge, and notably, 3 of those were complete responses.
That's impressive. Was that monotherapy or combinations?
That cohort used various strategies, including monotherapy or combinations like pembrolizumab plus lenvatinib or nivolumab plus ipilimumab. Another study by Rose and colleagues focused especially on adding lenvatinib to pembrolizumab rechallenge in deficient MMR patients who had progressed on pembrolizumab monotherapy, and reporting an objective response rate of 75%.
And what about current prospective efforts? Since the clinical community recognizes this need, what trials are on the horizon?
The sources highlight a growing number of trials addressing this. Most importantly, the NRGGY025 trial that is evaluating dual checkpoint blockade, nivolumab plus low-dose ipilimumab versus nivolumab alone in recurrent deficient MMR endometrial cancer patients who have had prior immune checkpoint inhibitor. Crucially, this trial mandates an immune checkpoint inhibitor-free interval of at least 12 months prior to retreatment, an emerging concept potentially borrowed from melanoma and lung cancer.
That nicely transitions us to our second paper, which deals with tumor characteristics, specifically aggressive histology in endometrial cancer. The article is Prognostic Value of Aggressive Histology in Surgically Staged Clinical Uterine Confined Endometrial Carcinoma, with first author Kristen Degger, affiliated with the Memorial Sloan Kettering Cancer Center, Department of Surgery, Gynecology Service, New York.
This study looks massive. What was their main objective regarding these aggressive histologies?
Well, the objective was to compare oncologic outcomes across the different aggressive histopathological subtypes of apparent early-stage high-grade endometrial carcinoma. They looked at 6 subtypes: FIGO grade 3 endometrioid, serous, clear cell, carcinosarcoma, mixed and undifferentiated adenocarcinomas.
Why is this grouping of aggressive histologies controversial?
The new FIGO 2023 staging system groups these subtypes together as a single staging criterion. The study argues that they shouldn't be treated as a single entity or used as a staging criterion because they are heterogeneous disease with distinct oncologic outcomes.
How significant was the variation in outcomes they found in their cohort of 1,087 patients? Who had the best and worst prognosis?
Well, the findings showed a significant variation. Grade 3 endometrioid adenocarcinoma had the most favorable prognosis, with a 5-year progression-free survival rate of 79% and overall survival of 83%.
And the worst?
Carcinosarcoma. It exhibited the poorest outcomes with 5-year PFS at 51% and overall survival at 54%. This confirmed their hypothesis that these subtypes are not prognostically homogeneous.
Did they determine if histology remained an independent prognosis factor even after adjusting for other clinical pathological variables?
Yes, they did. On multivariable analysis, several histologic subtypes remained independently associated with worse PFS and overall survival compared to grade 3 endometrioid adenocarcinoma. For instance, the adjusted hazard ratio for PFS for carcinosarcoma was 2.1, very statistically significant with a statistically significant p-value. They also found that peritoneal cytology, LVSI, lymphovascular invasion, and age at surgery were independent predictors of worse survival.
So the takeaway here is that prognosis factors should focus on disease extent with histology and molecular data used in a complementary manner, rather than relying on histology as a defining staging factor.
Exactly. Now, let's shift gears completely and discuss a detailed safety review focusing on a newer class of targeted agents. Our third article is Safety of Antibody-Drug Conjugates in Gynecologic Cancers, Current Evidence and Management Approaches. This was authored by Esteban Siliberti as the first author affiliated with Ente Ospedaliero Cantonale Oncology Institute of Southern Switzerland, Bellinzona.
ADCs are complex molecules. Matteo, for listeners who might need a refresher, what are the 3 key components of an ADC and how do they function?
Wow, nice question. An ADC is composed of 3 parts: a monoclonal antibody that binds specifically to a target antigen on the tumor cell surface, a cytotoxic payload that is potent, you think hundreds of times greater than classic chemo, and a linker that joins them together and ideally remains stable until drug release at the target site.
And while ADCs are designed for selectivity, they still cause high rates of toxicity. Since the safety profile is largely influenced by the cytotoxic payload, what are some of the hallmark toxicities associated with the approved ADCs in gynecologic oncology? Let's start with mirvetuximab soravtansine, or MIRV.
Mirvetuximab targets FR-alpha and uses a tubulin-targeting DM4 payload. Its most notable toxicity is ocular events, including keratopathy, blurred vision, and dry eye. This is considered an off-target toxicity because the human cornea cells don't express the target FR-alpha antigen.
And how do clinicians manage that significant ocular risk with MIRV?
Well, in these cases, prophylaxis is critical. Patients should receive guidance on eye care, including avoiding contact lenses, for example, or using lubricantized drops throughout the treatment. A baseline ophthalmologic exam is mandatory. Interestingly, corticosteroid eye drops were mandatory prophylaxis in the phase 3 Mirasol trial, though current EMA guidelines recommend them only for grade 2 or higher events.
And moving to tisotumab vedotin, which targets tissue factor, what unique safety issues does its payload, monomethyl auristatin E, introduce?
Well, this MMAE is also a microtubule disrupting agent. Similar to mirvetuximab, tisotumab vedotin causes ocular events and peripheral neuropathy. However, tisotumab vedotin's ocular toxicity is categorized as on-target, as tissue factor is expressed in ocular epithelium. Tisotumab vedotin also carries a risk of hemorrhage, which is a non-target effect resulting from tisotumab disrupting the extrinsic coagulation pathway by binding the tissue factor.
That on-target bleeding risk is unique. Finally, let's discuss trastuzumab deruxtecan. Its payload is a topoisomerase 1 inhibitor, deruxtecan. What are the two most critical adverse events of special interest for trastuzumab deruxtecan?
Well, trastuzumab deruxtecan is associated with a high incidence of gastrointestinal disturbances and fatigue. But the two most critical adverse events of special interest are interstitial lung disease or pneumonitis and cardiac toxicity.
Pneumonitis risk is approximately 10%, which can be fatal. How do we monitor for that?
Well, vigilant monitoring and early recognition are paramount. This complication is thought to be an off-target effect. Patients should have a chest CT scan before starting treatment and at least quarterly during the first year. For asymptomatic grade 1 pneumonitis, the recommendation is to withhold trastuzumab deruxtecan and consider steroids. If it's symptomatic, which means grade 2 or higher, permanent discontinuation and systemic steroids are required.
Well, thank you. This conversation really underscores the and management in gynecologic oncology. We've moved beyond standard chemo into nuanced strategies like checkpoint inhibitor rechallenge and highly specific ADC toxicity management.
Definitely foundational reading for anyone in the field. Thanks, Paula, and thanks to our listeners for joining us for the November's editor choice.
A huge thank you to you, Matteo, for such an insightful conversation, and thank you to all of your listeners for tuning in.
We encourage you to seek out these excellent articles for more in-depth information. You can find them in the International Journal of Gynecological Cancer. Thanks for joining us, and we'll catch you next time.